Hello, everyone. Welcome. So this is the breakout session, Sleep in Parkinson's Disease and Related Disorders. We're so glad you're here. And we do need to let you know that our speaker, Dr. Stuart McCarter, is from Mayo Clinic, and he actually is in Mayo Clinic. And he's presenting virtually today, but thank goodness that we have the technology to make that happen. We needed to make a change, and but we're here ready to go. So I have the pleasure of introducing Dr. McCarter, and with that, he's going to go ahead and start his program, Sleep in Parkinson's Disease. Thanks so much.
All right. Well, apologies, I couldn't quite hear the introduction, but it's my pleasure to be here. Unfortunately, I was planning on being there in person, but some unforeseen circumstances kept me here in Rochester, but glad that we have Zoom, and hopefully this will work out just about as well. I'm looking forward to seeing you all, hopefully someday in person. So I'm Stuart McCarter. I'm a graduating sleep fellow at the Mayo Clinic in Rochester, Minnesota, a neurologist by training, and want to talk to you today about something that's near and dear to my heart, which is sleep and Parkinson's disease and related disorders. We're going to spend most of the time talking about Parkinson's disease specifically, but we'll talk about a few specifics towards some other Parkinsonian disorders, as well as a lot of the sleep disorders are shared across all the spectrum of Parkinsonism. Go ahead, next slide, please. So just to start off with, I just wanted to mention that any medical information that's provided is solely for the purpose of providing information and not intended as medical advice, and that you should always discuss with your personal healthcare providers regarding specific medical and health-related instructions and guidelines. And then the last thing, I have no relationships with industry, so I have nothing to influence what I tell you today. Next slide, please. So I think that even though we all sleep, we're all familiar with sleep, I think it's always a good thing to start out about talking about just why we sleep, and that kind of helps frame maybe what happens when we don't sleep very well, or what issues go on with sleep and where they come from. And so the real reason that we sleep is for actually a lot of reasons. The first one being it's evolutionarily helpful to not be killed by the saber-toothed tiger, and they typically hunted and found their prey at night, and so to sleep was to keep you safe and quiet and away from the predators. Now, obviously that's not really the case anymore, but we've kind of kept that evolutionary framework, but we now use sleep primarily for other reasons, and that is, one is energy conservation. So if you are up walking around 24/7, of course you need to consume more calories, you don't really get a chance to rest and recover, and so that's what sleep plays a huge role in, that energy conservation. Along those lines, you get to rest, rejuvenate, restore, you can build your tissues that broke down, heal your wounds, all those kind of things. Sleep plays a huge role in our ability to learn and retain new information, to make and store memories, and to solve problems, either learning from the day or to kind of help our creativity to solve problems that we might come up in the future. Additionally, sleep helps us regulate our emotions, and so obviously I think we've all probably realized that we get a little bit more irritable, a little bit more short with others if we're a little sleep deprived, and that's part of the reason why sleep is so important from an emotional regulation standpoint. The immune system is also kind of fine-tuned and promoted during sleep. And finally, from a specifically interested to Parkinsonism and other neurodegenerative disorders, there is a brain cleaning system that's been identified within the last several years called the glymphatic system. And this is also active during sleep. And this is becoming a hot area of research in Parkinson's disease to see whether or not we can use this to kind of either reduce the progression or slow the progression of Parkinson's disease. So we sleep for a lot of reasons. It's obviously very important, and that's why we spend so much time of our lives sleeping. Go ahead, next slide, please. So unfortunately, I don't think I have a pointer here, so I'll just try to describe this graph for you. So to orient you, we're going to be talking about something that's called the circadian rhythm. And this is just a kind of a background, and this rhythm is in all of us. It is a 24.2-hour clock that basically tells us when we should be asleep and when we should be awake. And light exposure is the main thing that keeps this clock on schedule. So for instance, if we put you in a dark room for a month, your clock is still going to go 24.2 hours, but your sleep time, if you were to look at the clock, might be starting out, it's normal from 9 to 7, and then it's going to move from 10 to 8, and it's going to kind of slowly keep going back, because you don't have that light cue to keep you on time in terms of societal time. And so this is just a graphical representation of kind of how sleepiness works as part of that circadian clock. And so on the left side of the slide, you have, in that y-axis, so the up and down, there is sleepiness. And if you go up, there's more sleepiness, and down is less sleepiness. And on the bottom, there is the time of day, so 6 a.m. to midnight. And that W-shaped blue line is basically how much your body clock makes you want to sleep. And so like you can see at about 7 a.m. or so, it starts coming down because we're waking up from sleep. And then at noon, it's very low, so you're unlikely to sleep. There's that little siesta time at about 2 where we all get a little bit of want to take a nap after lunch maybe. And that's a normal part of our circadian clock. And then around 4 to 6, you become again not sleepy, and then that sleepiness kind of builds up in the evenings, kind of towards the end on the right side of that graph. So it's a pretty cool thing, and it can kind of slide all over the place, and it's probably affected in Parkinson's disease, which might explain some of the disorders in Parkinson's disease that we'll talk about in a little bit. Next slide, please. So what happens when we sleep? Sleep is basically a cycle. And you have stages of that sleep, and it kind of cycles throughout the night. And you have 4 to 6 sleep cycles on a given night. They each last somewhere between 70 and 90 minutes. And then at the end of the cycle, so you kind of start in light sleep, go down to deep sleep, and come back, and then you almost wake up. And then you kind of repeat this over and over and over again. And so we'll talk a little bit about each cycle going forward, but if you can go to the next slide. This is a graphical representation of what we see when we bring you in the sleep lab and look at your sleep. And so on the left side, so this is an overnight, it's called a hypnogram, and it summarizes the stages of sleep throughout the night. And I think this is a helpful visual because I think a lot of people sometimes have a little bit of a misunderstanding of what sleep stages mean what. And so on the left side, there's wake is at the top, REM sleep is those red lines, light sleep is the line below that, and then there's intermediate sleep and deep sleep down below. And so as you can see, on the left side is the beginning of the night. This person is awake. Then they go into light sleep, very brief, and then they go into intermediate sleep, and then they go all the way down into deep sleep. They spend some time into deep sleep, and then they come back up and get either, sometimes you go to wakefulness, sometimes you go into REM, and it kind of just depends on the individual that's having the study, but this is a kind of a general framework of what happens. And this is important to think about because actually deep sleep is true deep sleep. That's the restorative stage of sleep. Whereas REM sleep, what everyone tends to think as deep sleep, is actually the closest to wakefulness, but we're just paralyzed so we don't move. And you can do this throughout the night. There's a little bit of variation throughout the night in terms of how the sleep stages might change. So you get that more deep sleep at the beginning. So as you can see on the kind of the left half of the screen, or at least left half of my screen, where it's all the way down to deep sleep, there's more deep sleep at the beginning of the night, and there's more REM sleep in the second half of the night. So you can see there's more red lines in the second half of the sleep on the kind of to the right side of the screen here. Please go to the next slide. And this is just for people out there that are numbers, this is the relative percentages that we spend in these different sleep stages. Everybody's a little bit different, but this is on average. So we really spend not very much time in light sleep, about 5%, because it's kind of a worthless stage of sleep, to be honest. And you can fall in, and a lot of times people don't even think they're asleep when they're in light sleep. We spend the majority of our time in intermediate sleep, about 50%. And then about 20% in deep sleep and 25% in REM sleep. And these percentages are generally the same across our lifespan. And it's just the amount of sleep that was what changes, but the relative percentage of sleep stage kind of stays about the same. Next slide, please. So what's happening? I'm not going to talk about light sleep. Like I said, it's kind of not a particularly helpful stage of sleep for anything. But what's happening during intermediate sleep? So remember, this is where we spend most of our sleep. It's fairly easy to awaken someone from this stage of sleep. But this is kind of where the body restoration and rejuvenation begins. And so your heart rate goes down, your breathing slows down, your body temperature goes down. So if you kind of think about vegging out, for a colloquial term, that's kind of what happens as we go into kind of this intermediate stage of sleep. You do some dreaming, but dreams are kind of fuzzy. And if you wake someone up right after a dream, they're not going to really have crisp details that they can tell you about. But that body restoration is occurring. And you can have a couple various things that happen during during intermediate sleep. Sometimes you may kick your legs a little bit, but in general, it's just kind of a calm and relaxed stage of sleep. Please go ahead to the next slide. So what's happening during deep sleep? This is the stage that everybody wants to get and everyone's always worried about. And like we talked about on that graph, so this is that deep sleep. And that's why that graph is helpful, because you kind of go all the way down to that deep sleep and then you stay there. And so deep sleep is very, very difficult to awaken from. And that is because it is the most restorative stage of sleep. It's where really we're doing the most of our kind of recovery and building from the prior day and building for the next day. There are some things that happen out of this stage of sleep in terms of sleep disorders, particularly something that's called sleepwalking or a confusional arousal. And that is basically where, if you get awoken from deep sleep, your brain is in two different stages. So part of it is awake and part of it is actually still in this deep sleep. And so what often happens is if you get awoken during this time, people are very confused. They may seem awake because they're partially awake, but they may be mumbling nonsense or very difficult to kind of redirect and very confused. And so that's basically why, because the brain is kind of so deep in this sleep stage that it doesn't really realize that you've woken up. And it takes some time to kind of come out of it. And a lot of the times people won't even remember waking up from this stage of sleep if you wake them up. This is where your heart rate and your breathing is going to be the lowest. Your cells are rebuilding, your muscles and all of your tissues are growing and they're repairing themselves from the breakdown. This is where the immune system is going to really build its strength. And this is why sleep is an important part of your immune system. And then this is where that brain cleaning system, so that lymphatic system that we think is really important for cleaning out that alpha-synuclein that happens with Parkinson's disease and multiple system atrophy and dementia with Lewy bodies, or amyloid beta and tau that happens with Alzheimer's disease. This is really the stage that we think that system is active, and why we are so interested in seeing whether or not if we can improve your deep sleep, could that potentially have an impact in Parkinson's disease itself. Go ahead to the next slide. And finally, what's happening during REM sleep? So people, like I mentioned before, people think that REM sleep is our deepest sleep. But in actuality, REM sleep is the closest to wakefulness. So our brain activity is the closest to wakefulness. This is when we're dreaming, and dreams are vivid. And if you wake someone up during REM sleep, they'll remember, exactly what was going on. They can tell you everything that was happening. But because our brain is so active and because we're dreaming, we're supposed to be paralyzed during REM sleep. Because if you're not paralyzed, then you can act out your dreams and fight and kick and punch and run. And so that's what's happening in REM sleep. And because this is such an active stage of sleep, your heart rate becomes faster, your breathing is faster, you're more irregular in terms of the heart rate and the breathing. And so sometimes people might see a little bit of a panting sort of thing and get a little bit worried, but that's a pretty normal part of REM sleep. And maybe any of you that have dogs have seen your dog kind of, to twitch their feet or, kind of raise their mouth or bark a little bit. That's usually REM sleep. REM sleep is important for multiple reasons. So it consolidates what we have learned during the daytime, and it sharpens our memory. It's incredibly important for the processing of our emotions and our motion regulation. And it's important for actually developing our motor skills during development. And part of that is that that sleep paralysis that we get with this is the brain kind of sends those signals to just test out the pathways and kind of build the strength during sleep. And because, like we've talked about, some people do get unparalyzed during REM sleep, and particularly people with Parkinson's disease, you can act out your dreams, something called REM sleep behavior disorder that we'll talk about a little bit later. Go ahead to the next slide. So normal sleep time decreases with aging. On average, when we're just born, you need about 14 hours, and that time just steadily declines to about, on average, and this is on average, 7 to 5.5, 6 hours, basically after age 45. And so we all unfortunately kind of just lose sleep over time, and that's part of the normal aging brain. But what happens in sleep in Parkinson's disease? So go to the next slide. So as you've seen, so we know that in normal aging, we lose sleep time. In Parkinson's disease, that sleep time goes down even further. And that's for multiple reasons. Part of it is because you're just getting more light sleep, so that kind of relatively not good sleep. You're having less intermediate sleep. You have less of the deep sleep, and the deep sleep that you get is kind of more fragmented or interrupted, and you get decreased REM sleep. So all those things basically go down, apart from that light sleep kind of goes up a little bit. And go ahead to the next slide. So now that you know a little bit more about what sleep is and what normal sleep is, let's talk about what goes wrong in Parkinson's disease and similar disorders. And we're going to talk about 6 sleep disorders that happen fairly commonly in some depth, and then talk a little bit about a few additional things and a couple other Parkinsonian disorders for the rest of the talk. So people in Parkinson's disease, unfortunately, have a lot of sleep problems. And I think a lot of the time it's under-recognized or at least underappreciated, and we just kind of, attribute it to, well, yeah, things happen. But they can cause a lot of real problems, both in terms of being refreshed and, functioning during the daytime, as well as affect your motor symptoms. And so these sleep disorders are insomnia, which we'll talk about. Hypersomnia, or excessive daytime sleepiness, is the other term for that. Obstructive sleep apnea, REM sleep behavior disorder, restless leg syndrome, and then altered circadian rhythm. So remember, that body clock that we talked about becomes altered in Parkinson's disease. So let's talk about insomnia. Go ahead to the next slide. So insomnia is the inability to fall asleep, maintain sleep, waking up earlier than you want to, or just generate quality sleep that leads to an impact on your daytime functioning. That might be cognitive slowing, that might be falling asleep accidentally or during the daytime. But basically, it's a difficulties with initiation and maintenance of sleep that leads to daytime dysfunction. It's very common. It's probably the most common sleep disorder in Parkinson's disease. At least 50%, and some studies will even say 80% of patients will have with Parkinson's disease will have insomnia. And unfortunately, there are a variety of different reasons that patients with Parkinson's disease can have insomnia. So it might be your Parkinson's symptoms. It maybe is the tremor keeping you up. Is it the stiffness that you have, difficulties getting comfortable in bed or rolling over, or maybe your slowness in movement that just makes it really hard to get comfortable and fall asleep. Mood can really be a huge thing in Parkinson's disease, and mood is a huge part of your sleep. If you're anxious and worrying about a variety of things, it's hard to turn that mind off and start your sleep. Depression, even if you're not sad during the day, you can be depressed without feeling sad. And one of the first signs of depression is actually waking up earlier than you want to wake up. Unfortunately, Parkinson's has a lot of pain. And if you're in pain, it's going to be hard to turn your brain off, get comfortable, and fall asleep. Getting up to go to the bathroom, that's going to interrupt your sleep. Drug effects, so particularly carbidopa, levodopa, and dopamine agonists, even though they can both cause sleepiness, they can actually also cause insomnia. And so thinking about that, and did the difficulties with sleep start whenever you changed your dose or started a new medication or started taking it later? There are other sleep disorders that can prevent you from falling asleep or staying asleep, and these are going to be things like sleep apnea, restless leg syndrome, REM sleep behavior disorder, and we're going to talk about those later. And then that circadian rhythm, like we talked about. So, that circadian rhythm can change. And if that circadian rhythm is saying, well, actually, you don't get sleepy until 1 a.m., it's going to be really hard to fall asleep at 10 p.m. And so kind of if that circadian rhythm gets messed up, either because of the Parkinson's disease itself or because we're not being as active or getting exposed to light or having that routine schedule, that can make it difficult to fall asleep or stay asleep. And then finally, something that I think people often don't appreciate is alcohol. So alcohol helps you fall asleep. But when you metabolize the alcohol, it becomes a stimulant. And so you might notice that, sure, I fall asleep pretty well with alcohol, but then all of a sudden 4 hours later, wide awake. And that's because the stimulant is kind of kicked in as the alcohol is being broken down. So another thing to think about when we're talking about difficulties falling asleep. Go ahead to the next slide. So when we talk about managing these symptoms, the management depends on identifying what's the main cause. And so if it's the Parkinson symptoms, then we might say, all right, should we take a longer acting medicine at night? That might help us stay asleep, prevent that tremor from coming back up, prevent that stiffness or slowness from kind of reemerging while we're sleeping. I certainly have many Parkinson's patients that have a dose of carbidopa-levodopa on their bedside table. So when they wake up at 3 a.m. and they have a tremor or they're stiff, they just take it and go back to bed, and it helps them fall back asleep. We're knowing more and more now that these more continuous acting medications, so maybe the rotigotine patch, the apomorphine continuous infusions, the Duopa intestinal gel, if we continue that overnight, the studies are really showing that sleep symptoms tend to improve in patients with Parkinson's disease, at least in the clinical trials that have been looked at in those patients where they've continued the treatments throughout the night. If it's the drug effect that's been the problem, maybe you reduce your dopamine dose, or maybe you change the timing. So for instance, if you're taking a 10 p.m. carbidopa-levodopa dose and you can't fall asleep because you just feel wired, maybe try taking it at 8 and see if that wiredness kind of helps kind of wean down and let you fall asleep. So it does take a lot of kind of really parsing out as to when did this start and what's the problem. It's going to be those things to address. If you're anxious, addressing that, either talk therapy. We're going to talk a little bit about what our mainstay of treatment for insomnia is in Parkinson's disease in a little bit, called cognitive behavioral therapy. But assessing that mood. Is depression an issue? Treating depression might allow you to sleep through the night a little bit better or prevent that early morning awakening. So really kind of looking at, is our mood in a good spot? We need to address other sleep disorders if they're there. So if you're snoring and you're stopping breathing, do you have sleep apnea? Do you have restless legs that's making you need to get up and walk around that's preventing you from falling asleep? Or maybe you have REM sleep behavior disorder and you act out your dreams every night and you wake up and then you can't get back to sleep either because the dream was bad or you hurt yourself or whatever it's going to be. So we have to look for these other sleep disorders and treat them if they're there. If it's the problem that circadian clock, so that, that regular 24-hour clock is starting to get misaligned, and that's what we call it when it's not matching up to where we want it to be. As we talk about getting regular scheduled light exposure, regular physical activity, regular scheduled meals, and kind of minimizing napping, because napping can kind of dislodge or displace that curve a little bit. And then finally, certainly we do use some medications for insomnia. Of course, all of these things have side effects potentially, and you should always speak with your doctors in terms of your personal health situation, because everybody's a bit different. But melatonin does have some benefits in terms of falling asleep. It doesn't really help you stay asleep. There are some hypnotic medications, so something like that's called low-dose doxepin has been shown to be effective in Parkinson's disease, but it does carry with it some side effects, particularly kind of dry mouth and dizziness when you go from sitting to standing. So if that's already a problem, it's not a great thing. And then a lot of the times we'll add a long-acting Parkinson's disease medication at night to try to kind of smooth out that dopamine curve and keep you kind of level and hopefully preventing the Parkinson's symptoms from coming back out. And then the last thing, like we talked about from an alcohol standpoint, is to limit the alcohol. If you're like, oh yeah, I have a beer or two every night, and you're waking up in the middle of the night every night, cut the alcohol out. See if that makes things better. Go ahead to the next line, or next slide, sorry. So this is that circadian rhythm drawing again. And this is going to be our prelude into talking about cognitive behavioral therapy, and that's kind of a brain training thing that we do for insomnia. But there are two processes that help us schedule our sleep and get to sleep. And so, like you can see in blue, there's that W blue that we talked about. That's that circadian rhythm. So the peaks where it's high is promoting sleepiness, where it's low, the body doesn't want to sleep. And now I've added this yellow line, and that is called the sleep drive. So that is your brain, basically brain's desire to fall asleep. Theoretically, when we go to sleep and we sleep, that sleep drive goes all the way down to 0. And once we wake up, it starts building. And in an ideal world, you wake up at whatever time it's going to be, you stay awake the whole day, that sleep drive keeps building, building, building. And sometime in the evening, whatever it might be, depending on where your clock is, you want that sleep drive and that circadian rhythm to kind of be at the maximal likelihood of sleepiness or maximal likelihood of going to sleep. And that's what that red box is on the right side of the screen. And, hopefully those two go together and you're going to be likely to fall asleep. Now, if there's a mismatch between those two things, then let's say, for instance, at 6 p.m. there, the circadian rhythm doesn't want to sleep, but your brain is pretty sleepy. So it's unlikely you're going to fall asleep. There's that afternoon lull like we talked about. And so as you can see, there's that little peak in the blue line at about 3-ish p.m. And the yellow line is going up too. And actually, so they kind of match there. So the brain sleepiness and the body sleepiness at about 3 o'clock tend to match up. And that's why most of us get a little bit sleepy and why they have a siesta or that scheduled nap time in some cultures to kind of, get through that period and then be refreshed for the rest of the day. Now, the problem is once you go to sleep, that sleep drive goes down. So if you take a nap for 2 hours from 3 p.m. to 5 p.m., all of a sudden your sleep drive had been, halfway up this line. Now it's back to, close to zero. And so it's got to rebuild. And now that sleepiness isn't going to be present until later. And so it might be harder to fall asleep at your intended bedtime. And so that's kind of the theory or kind of the process that's going on with our sleep. It's these two processes. Go ahead to the next slide. And so that brings me to the best treatment for insomnia. Once we've kind of ruled out all the other things that we've talked about, the other sleep disorders, Parkinson's symptoms, things like that. And this is to basically change how your brain perceives sleep. And so much of insomnia is learned. And basically, we are all predisposed, some of us more so than others, to have insomnia. Oftentimes there's an event, maybe it's an illness, a stressor, whatever it is, and you don't sleep. And you basically say, okay, I need to sleep more to recover from what I did. And that kind of perpetuates the inability to fall asleep because you're starting to train your brain to go to sleep when you're not sleeping. And so how do we kind of try to fix this? The main things are going to be to maintain a regular sleep and wake time, keep that regular schedule. We want you to have regular light exposure, normal daytime cues, meals, getting outside, social activities, things like that, and minimizing those long daytime naps, because if you take those long daytime naps, it's going to be harder to fall back asleep later. We want you to limit the time in bed. Don't make up for lost sleep, because the more you try to force yourself to sleep, the less likely you are to sleep, and it's just going to make things worse. And we want you to go to bed when you're sleepy. But if you're not sleepy, we don't want you to go to bed. And then finally, if you're having a hard time falling asleep, we want you to not stay in bed trying to force it. We typically recommend trying to get out of bed, do something boring without light exposure, like reading a boring book. And then as you get sleepier, then you try to go back to sleep and reinitiate sleep that way. And the more you do that, the more you train your brain to be sleepy in your bed. And then finally, limiting afternoon caffeine. So typically after 2 p.m., get that out of there. That can prevent you from falling asleep. And then setting some time during the day to just worry about things. Because if you're an active mind and worrier, I got to do X, Y, and Z tomorrow, write it down. And that kind of helps make it concrete and kind of let you let it go. And that's basically where we're at from insomnia. So let's go to the next slide. The next, so hypersomnia is the opposite of insomnia. And this is being excessively sleepy during the daytime despite getting sufficient sleep opportunity. It's present in about 30% of Parkinson's disease patients, and it tends to occur longer as the disease has been around for longer or with more severe symptoms. And it can be caused by a variety of things. It can be caused by Parkinson's disease itself. So it's probably part of the Parkinson's process in the brain that makes you sleepy. Other sleep disorders can make you sleepy during the day. So if you have insomnia and are only sleeping a couple hours at night, you're going to be sleepy during the day. Maybe you have sleep apnea or restless legs, things that are preventing you from falling asleep or staying asleep. That can make you sleepy during the day because you're not getting enough sleep. Medications can cause sleepiness in Parkinson's disease, and particularly the dopamine agonists are the main things that we think about. And so if a significant amount of sleepiness has come on as you've increased those doses, that's something to think about. And then finally, depression that's untreated is another main cause of sleepiness. Go ahead to the next slide, please. So how do we manage this? Well, the first thing is to figure out if there's another sleep disorder that's the problem. So if you have sleep apnea, we try treating it, see if that makes you better. If you have insomnia, try to work on the insomnia to get you some more consolidated sleep at night. Do you have restless legs? Try to treat the restless legs and see if that makes things better. We want to make sure that your symptoms of Parkinson's disease are adequately treated at night, because obviously that can interfere with your sleep. And then we want to think about, did the sleepiness start with our medication change or our dose increase or something like that? And then considering adjusting that if you can identify that as the trigger. There's some evidence that light therapy, bright light exposure upon awakening, either in the form of a light box or just getting outside, which is what I prefer. Of course, in Iowa in December, it's a little bit hard, but getting some bright light and regular activity is going to help wake the brain up a little bit and keep you a little bit more alert. And then sometimes, despite all these things, people are just still sleepy, and we'll try some medications that kind of give you a little bit of boost. That's called the stimulant medicine. There are not a lot of great data in terms of Parkinson's disease and which works well, but modafinil does have, which is one type of stimulant that we'll use in Parkinson's disease that can sometimes be helpful. Go ahead to the next slide. The next sleep disorder that's common in Parkinson's disease is obstructive sleep apnea. And so what this is basically blockage of airflow through your mouth or your throat by your tongue, excess neck tissue, or soft tissue that's in your throat. And what ends up happening is as we sleep, all of our muscles relax and our tongue gets a little bit floppier, and it's more likely to kind of block off the throat and lead to basically air not getting through. And the symptoms that will come with this are going to be snoring. So as that tissue kind of narrows the airway, the tissues vibrate and it causes snoring. You may see someone stop breathing and then kind of come back out of it, or they have those choke and gasp arousals where they sort of snort themselves awake. And those are kind of all, that's the brain waking you up saying, whoa, your oxygen's going down, we need to wake you up here, bring it back up. And if you do that several times an hour throughout the night, it's going to interrupt your sleep and potentially make you tired during the daytime. Other symptoms that may come with this are going to be things like dry mouth, sore throat, or headaches whenever you wake up. So these are things to think about, listen for, ask your doctors about. It's very common in Parkinson's disease, somewhere between 20 and 60%. And like I talked about, it can lead you to not be able to stay asleep typically is the main thing. And because you're not staying asleep or getting that good kind of continuous sleep like we want, going through all those stages, it can lead you to be sleepy during the daytime. And sometimes it's as simple as treating sleep apnea and you never knew you could feel so good. How do we manage obstructive sleep apnea? So we work on weight loss because extra tissue around the throat or around the belly is going to make sleep apnea worse. We avoid alcohol because alcohol makes everything more floppy and makes sleep apnea worse. And then otherwise, we'll do treatments to try to open the throat and the mouth and basically get the tongue out of the way so it can't block things off. And that could be in the form of a mouth guard called an oral appliance, or most of you or some of you have probably heard of something called CPAP or continuous positive airway pressure. And that's just air that's being forced down your throat to kind of keep everything open and let you just breathe normally. And then there's actually some interesting data from just a few studies that have shown that maybe long-acting carbidopa-levodopa might actually help treat sleep apnea in patients with Parkinson's disease as well, although I'd say I haven't had the most success with that in my experience. Go to the next slide. The next sleep disorder, and probably the one that I've spent the most time in my career studying, is called REM sleep behavior disorder. And so like we talked about, REM sleep is that dreaming sleep. So we're supposed to be paralyzed. In REM sleep behavior disorder, you lose that muscle paralysis and you act out your dreams. Classically, patients might say, I've been attacked by X, Y, and Z, or a snake chased me, or someone was fighting with me. Very rarely do patients describe themselves as aggressors, but every once in a while that may happen. And in the setting of these dreams, you may kick, or you may punch, or you may scream, or you may jump out of bed trying to catch a football. These episodes are typically going to be on the shorter side. So they're not going to be these long, 5-minute things. They're going to be pretty short, less than a minute. More oftenly, they're going to happen kind of between 2 and 7 in the morning. That's when that REM sleep is the most. Whenever you look at someone that's doing this, they'll be asleep. Their eyes are going to be closed, even if they're yelling and screaming at you. And typically, if you waken someone up, they'll be able to tell you what they were dreaming about. And I should say that most of the people will describe these chase or attack themed dreams, but that's not the case. I have plenty of patients that dream of flower picking or playing the piano, and then they wake up kind of finding them, tickling the ivories in space or something like that. So while most of what you'll read is about these violent behaviors, it can be a whole variety of spectrum of behaviors. Patients generally don't walk around the room. They don't appear confused, like that confusion arousal coming from the deep sleep, which is a different thing. And then injuries are pretty common, unfortunately, to either patients or your bed partner from being punched or kicked, and these can be serious. So it's something very important to think about and look for. It's present in probably 50% of patients with Parkinson's disease, and it can either be before any of the tremor, the slowness, the stiffness. It can happen as those symptoms come out, and occasionally it can happen after you've had Parkinson's disease for years. So that's relatively rare. It's more going to be the before Parkinson's symptoms, sometimes up to a decade or more, or kind of as the Parkinson's symptoms come out. And interestingly, as kind of, you live longer with REM sleep behavior disorder, symptoms actually tend to get better and less violent. Go to the next slide. So unfortunately, our treatments for REM sleep behavior disorder are not the best. They're all probably about 60% effective at best. And our goal is really to reduce those severe punching, kicking, jumping from bed behaviors. You may still have a little bit of, hand twitching or talking. And unfortunately, at least with our current management strategies, we really don't have anything that totally gets rid of all the symptoms. The main thing is to keep a safe bedroom. Getting the bed, if you're someone that jumps out of the bed, get the mattress on the floor so you really don't fall that far. Sometimes bed rails to keep you in bed if you're not willing to put the bed on the floor, because obviously it's hard to get out of bed if it's so low, or putting barriers between you and your spouse. If you're sharing the bedroom, sometimes spouses have to leave the bedroom for their own safety. We want you to remove objects that pose an injury risk. So that's going to be things like firearms in the bedroom. We want you to get those out, or at least have them locked. Because if you get your hand on it in a dream and you discharge it, you never know what can happen. You should move your bedside tables away. So things with sharp corners, pad those. Just anything where if you lash out and hit, you might bruise yourself or hurt yourself. And then anything else that you could grab, like a lamp or a watch, get that away so you just can't get it and use it as a weapon, as part of your dream. From a medication standpoint, so we use these in patients that are having frequent and injurious behaviors. Everyone is a little bit different, so talk to your provider about what's best for your situation. But generally speaking, melatonin is our first line therapy, just because it's pretty well tolerated. And there's probably better data for immediate release melatonin than the prolonged release melatonin. You typically need pretty high doses in the range of 10 milligrams or more, which is more than we typically would recommend for kind of just trying to fall asleep or for insomnia. Clonazepam is another option, can cause some more side effects, but is also very effective. Pramipexole or Mirapex can help in patients with PD specifically, and then rivastigmine, the patch form, is very helpful in patients that have some cognitive impairment. It can also help reduce dream active behaviors. The next thing is restless leg syndrome, and I think a lot of people think that, I jiggle my leg, I have restless leg syndrome. And that is actually either anxiety or habitual leg jiggling, and I have both of those. But restless leg syndrome is something that's called, or is an irresistible urge to move. So if you do not have this urge, that's just horrible urge to move, like being tied down is going to be your worst nightmare, then it's not restless legs. It's got to be present at night, at least initially. It has to be worse if you're laying or sitting, and then significantly improve or entirely go away if you get up and walk around. It's not just changing positions or rolling over that makes it better. That's positional discomfort. And unfortunately, restless legs is mimicked by a lot of Parkinson's symptoms. So the dystonia, those muscle cramps, that restlessness, that akathisia that you might get, or the slowness or the stiffness. So it can be really difficult. People can kick frequently with restless legs, but just because you kick does not mean you have restless legs. Happens in about 15% of Parkinson's patients. And really the main thing is it can prevent you from falling asleep, or sometimes if you wake up, and it can prevent you from falling back asleep. The management for this includes a variety of things. So stretching, massaging, heat, exercise, mental living techniques to just not think about the symptoms. Iron deficiency is very common and worsens worsens restless legs. So making sure that iron levels are normal and supplementing them if they're low. So we like a ferritin level of more than 100 and a transferrin saturation of more than 45% if we're talking about IV iron replacement. And then some of the medications for Parkinson's disease, particularly dopamine agonists, are very effective, but can actually, if you use them for long enough, can cause something that's called augmentation, which is actually worsening of the restless leg symptoms. So it can be very tricky. And then otherwise, we'll use things like alpha-2 delta ligands or gabapentin, neurontin is the other name for it, or pregabalin or Lyrica. And sometimes we'll use benzodiazepines or opioids, but all these require, obviously, subspecialty referral to discuss. Go ahead to the next slide. And then the last thing we're going to talk about is that circadian rhythm. So this is that slide again. 24 hours, light is the main thing that keeps it going. And it can shift depending on if we're getting adequate kind of cues for this. Go to the next slide. And so circadian rhythm abnormalities cause sleep disturbances because the circadian system is not aligned between basically socially determined sleep-wake schedules and what your body wants to do. And I'm sure many of you with Parkinson's have noticed that your symptoms tend to fluctuate throughout the day. And some of that is related to this system. And we're working on trying to figure out, is there a way to kind of optimize this system to help with Parkinson's disease symptoms? These abnormalities, so this dysfunction of the system happens, like I said, because we just lose those normal signals to keep our body clock on a schedule. And that light is the most important thing. And this happens partially because Parkinson's disease involves structures that are involved in this circadian rhythm maintenance. But also, as we have symptoms, maybe we don't get as much light stimulation because we're spending more time inside, we're not spending as much time interacting with others, or we're just being less active. And so those two combinations, so the Parkinson's disease itself, and then maybe some of our behavioral changes, can really let that clock to be wildly misaligned and cause a lot of problems. Generally speaking, bright light therapy and some melatonin can kind of help keep things on a schedule. And then physical exercise probably also has a role and kind of help your Parkinson's disease symptoms, and will kind of help you keep regular and making sure that you're awake during the daytime as well. And like I said, that regular sleep schedule is just that main big thing. Go ahead to the next slide. And then just going to quickly overview a couple of the other things, and then we're almost done. So in dementia with Lewy bodies, which is a cousin to Parkinson's disease, but different, really a lot of the same sleep disorders happen. And the management really does not differ a whole lot. REM sleep behavior disorder is probably a little bit more common in DLB than it is in Parkinson's disease. And less is known about the circadian rhythm abnormalities, and there's probably a little bit more sleepiness in DLB compared to Parkinson's disease, but really the management is kind of the same that we've already talked about for Parkinson's disease. Go to the next slide. Multiple system atrophy is a different Parkinsonian disorder, but still an alpha-synucleinopathy like Parkinson's disease and DLB. So again, the sleep symptoms are going to be pretty much the same, but sleep disordered breathing, so sleep apnea is more common. Patients with MSA have more dysfunction in the part of the brain that controls breathing, and so you can get a different type of sleep apnea called central sleep apnea or hypoventilation, which is basically just not breathing as deeply and as much during sleep. And then the thing that we always question everybody for is something that's called stridor. And this happens in about at least 35% of patients with multiple system atrophy, and it first can often happen during sleep. And it's this high-pitched, harsh sound, it kind of, hopefully that's not too loud in the audience, but that happens during sleep, and it's because the vocal cords are just not opening correctly. And this can eventually happen during daytime, but again, it's more common during sleep. It might have some prognostic significance, and so it's really an important thing to screen for whenever you're talking, either just as family members or when you're talking with your providers, because we treat this with CPAP like we do for sleep apnea, or sometimes with a tracheostomy, which is kind of a hole in the throat here to get past those vocal cords. REM sleep behavior disorder also happens in multiple system atrophy. It's probably nearly universally present in MSA, and hypersomnia also is maybe more common, so that excessive sleepiness is also more common in multiple system atrophy. Next slide. And then the last sleep disorder we're going to talk about, or specific to a different Parkinsonian condition, is supranuclear palsy, or progressive supranuclear palsy, caused by a different protein than the others that we've talked about so far. But the main thing that patients with PSP complain of is severe insomnia. And it's probably largely because there's having to go to the bathroom in the middle of the night, and impaired mobility because you're so unsteady on your feet. But it is really hard to fall asleep and stay asleep. And unfortunately, it can be very difficult to treat. This is an active area of ongoing research. And so hopefully we'll have some better ways to treat this in the near future as some of these studies come out. But certainly talking to your providers and trying medications is a reasonable approach, and it just takes there's not a lot of good evidence to guide you, and it just takes some trying and seeing how things work out. And other sleep disorders like REM sleep behavior disorder, restless legs, those things are relatively uncommon in PSP. Go to the next slide. So my last two slides, I think there are some common things that I get questions about in the clinic. And the first one is going to be, how do I increase my REM sleep and deep sleep? I think a lot of people want to know, how can we do this? And unfortunately, we really are not very good at this yet. There's evidence that if you get regular aerobic physical exercise, so walking, biking, running, tends to make your sleep deeper and more consolidated. So that may help improve some of those sleep stages and sleep durations. Medications and supplements say a lot of things, and they'll say, take this REM sleep supplement and you're going to get more REM sleep. I think the data on that is really unclear, and it's also not clear if medication-induced deep sleep and REM sleep is the same as what your natural brain generation is. So that's still an area of active research as well. For patients with insomnia, we know that cognitive behavioral therapy that we talked about before does improve your REM sleep and deep sleep and helps your sleep consolidation, so making that continuous sleep. And mindfulness, yoga, Tai Chi may also kind of help with sleep consolidation and getting into that deep sleep, and that's another thing that can help with your Parkinson symptoms as well. Another common thing that I get is my wearable or my phone, my Fitbit says I don't get enough good, deep or REM sleep. To be honest with you, these are kind of helpful, but a lot of the time they can cause more problems. They use algorithms that we don't really know. We don't know exactly what these wearables are measuring, and certainly they've been, tested in people that are healthy that don't have Parkinson's disease or Parkinsonism. And a lot of them use kind of movement as a surrogate for sleep. And so if you have a tremor, it's going to think you're not asleep, even if you are asleep. And so I generally take those with a grain of salt, and I recommend people don't focus on them too much because it can cause insomnia because you're worried about not getting the deep sleep and the REM sleep. And so take it with a bit of a grain of salt. And I think that practically our abilities to modulate sleep are currently very limited, but this is an area of very active research, looking at ways to stimulate the brain to try to improve sleep, medications to try to improve sleep, and see if this can kind of slow progression of Parkinson's disease or other things like that, or make daytime functioning or symptoms better. So this is probably going to be a very hot area of research for the next few years, and hopefully we'll have a lot more tools in our tool belt within a short time frame to kind of help improve sleep symptoms. Next slide. So just to end, and thanks again for letting me be here. Like I said, I wish I could be there in person to see all of you and answer some questions. But I think the things I'd like you to take home is that sleep disorders are really, really common, and I think under-recognized in Parkinsonism, and they certainly ruin your quality of life or worsen your quality of life. And so either for providers in the audience, ask your patients about their sleep symptoms, or patients and spouses, caregivers, family members, ask about sleep, because a lot of times people are stoic and they don't want to talk about, I'm going to be okay. But sometimes it's a pretty simple fix, and the worst thing you can do is ask. Should screen for insomnia, screen for excessive sleepiness, ask about snoring and stop breathing, ask about, punching, kicking in your sleep, and then ask about, what are you doing during the day? Does it seem like you're not getting enough light exposure activity? Ensure that Parkinsonism is treated at night, and try to adjust medications or doses if that's the case, if it seems suboptimal. And then certainly, either refer to us or ask for a referral to a sleep specialist to kind of look into things a little bit further whenever you want or whenever you think it's appropriate. Make sure as best you can to just really kind of try to maintain a regular sleep-wake schedule. That's going to make things easier for you and make your sleep better. Maintain that regular light exposure and get that regular exercise. I usually recommend getting outside right after get your morning coffee and get outside, get some bright light. That helps you get your exercise in and that light exposure, and kind of keeps you on that regular clock schedule. And really just do your best to not force sleep, because the more you force it, the less it's going to happen, and minimize those long naps during the daytime, because it's going to make it harder for you to fall asleep and stay asleep at night. And like I said, this modulating sleep and the circadian rhythm to improve Parkinson's symptoms is an active area of research. And I'm very, very hopeful that we'll have some better information and better treatments for us in the near future. So I really thank you all for your attention. Hopefully it worked out okay on Zoom, and I wish you all the best.